This is Nevada NewsMakers with host Sam Shad, a no-holds-barred political forum. Now, from the Nevada NewsMakers broadcast headquarters, here is Sam Shad.
And back on Nevada NewsMakers, we are pleased to welcome to the program for the first time Dr. Paul Hiss and Dr. Doug Devries. Pleasure to have you both on the program.
Thanks, Sam.
And you're both eye doctors, so let's put that on the table. I wanted to ask you, first of all, your thoughts on the Affordable Care Act and how that's going to affect you and your business.
Well, nobody's really sure how many changes are coming down the road with the Affordable Care Act and other laws related to that, because the Affordable Care Act has set in place different levels of bureaucracy, which will then have the ability to decide a lot of the things now that doctors and patients are deciding. What type of care might be available to you, what type of procedure, how long you have to wait for a procedure, etc. And those administrative levels haven't necessarily been set yet. So we don't know who's going to occupy those or what they're going to decide. So right now there's a big question mark on how this entire law is going to be implemented and what that's going to mean to the doctor-patient relationship.
And you've got this on two levels, because you've got federal regulations coming down from this, but you also have state regulations from the board that the governor has appointed that will oversee all of this.
Yeah, absolutely. And even though we really don't know exactly how those are going to be implemented and who's going to be directing those and governing those, we're already feeling as a business and as a practice some of the effects of the Affordable Care Act in recredentialing, in certain levels of regulation that we're having to comply with at this point. And just the early levels that we're getting, a lot of it is quite onerous and difficult as not only a practice but as a business as well.
I think a lot of people don't understand that when you think of health insurance, you think of a medical doctor. They don't usually think of their dentist or their eye doctor. So right now you're able to take insurance, is that correct?
Yes.
Okay, and how often what kind of surgeries do you guys use with insurance? Because I still think of this as more optional than it is a surgical procedure that is covered by insurance.
Well, you might be thinking a bit about an optometry practice that provides some medical care to patients, but in large part does optical needs for patients, prescribes contacts, makes glasses. Mm-hmm. We don't do that. I'm a medical physician. I do medical and surgery of the eye, and that's just as medical and surgical as for your knee or your heart. So we are falling under the same laws as a medical practice that any medical specialty would.
Mm-hmm. What do you think in terms of the patient's responses to the Affordable Care Act? Because they're having a reaction and coming in the door and talking to you about this as well, I'm sure.
That's a great question. And on a daily basis, I get patients that are concerned about what's going to be there for them and what isn't. Is something that is covered now, is that going to be covered down the road? And unfortunately, we don't have those answers.
But at some point, I guess by October, they're supposed to issue all these regulations and pricing structures and everything. Do you think they're going to make that target?
No, I don't think so. And I think built into the law is the ability for bureaucracy to create other bureaucracy. So the answers are not going to be here in October, I'm afraid to say. This is being implemented in a very slow pace, and the decision makers haven't really been appointed yet. So I don't see how it could happen in a couple of months.
Do you think the ultimate goal is to force the country into a single-payer system?
That's my impression of the legislation, that really it won't succeed until they've accomplished a single-payer system from the goal that they've outlined. I absolutely feel that way.
That's a little frightening prospect when you think of this is an important relationship between a patient and a doctor, and to have the government coming in there. If you could sit on the exchange or work with some of the bureaucrats that are doing this, what kind of advice would you be giving them on how better to handle what we should be doing in our health insurance?
Well, I think one of the first things is the availability of insurance that does cross state lines. The other thing that has to be taken care of is tort reform, and to really ensure that relationship between a patient and a doctor and be able to explain to a patient what their options are. I think that's essential as well.
I think the number one essential thing in medicine is protecting the patient's right to choose the physician that they want. And more bureaucracy involved, the less the patient has the ability to choose the doctor they want. And the less the doctor has the ability to choose the medication or the procedure that would benefit the patient the most, because that has already been set in stone by levels of bureaucracy, that if this is the condition, then you have to do this or that. Well, every patient is different, every situation is different, and you just can't go by a checklist at all times. So I think the doctor-patient relationship, I mean, that is what medicine is all about. And when you lose that, you lose care. Patients suffer a loss of care.
I wanted to ask you one more political question before we get into more areas of expertise, which is the margins tax. What concerns, if any, do you have about that coming down the pike?
Oh, I have tremendous concerns about the margins tax. I mean, for a tax that is going to be off of gross revenue, irrespective of the net revenue, can have a devastating effect. And then, you know, are you combining businesses? Are you taking from different entities to combine that if they're the same ownership? There's some frightening aspects of that is, yeah, I'd really hate to see that come to fruition.
Well, we're also setting up an IRS essentially for the state of Nevada.
Yes.
And it's, you know, if you've seen the form that comes out of the state of Texas, it's 12 pages. It's pretty much like doing your federal tax returns. So it's not only that, but really what is driving this is the misnomer that it's actually going towards education, when all it really is doing is building up our state budget. And maybe if we had more accountability, we'd be a little happier there, but that's part of the challenge too. What are you looking at in precautions that you might be taking for both affordable health care and margins tax as you're preparing for, you know, the next couple of years in your planning?
Well, I don't know that we're having precautions as much as we're trying to comply. And that is a major undertaking, is just complying. We had to have electronic prescriptions that are sent in. That's mandated and in place right now. We have electronic medical records that soon that date will be mandated as well. All these are huge onerous tasks for a business, let alone somebody who's in the business of taking care of patients to try and accomplish on a daily basis. So, I mean, and something as simple as electronic prescribing has increased our workload tremendously, because now instead of giving a prescription to a patient and have them go to a pharmacy where it's between the pharmacist and the patient, now the patients are coming back to us saying, well, they say they don't have it. They say, and so now we're having to stop. We're having to look up information. We're having to. So it just is. The implementation and compliance is what we're trying to do. There's not a whole lot of prevention right now.
Yeah.
All right, let's take a break. More on Nevada Newsmakers when we come back.
And now, back to Nevada Newsmakers with Sam Shad.
And back on Nevada Newsmakers, we continue our conversation with Dr. Paul Hiss and Dr. Doug Devries, both eye doctors.
So you do some servicing throughout the state. And I'm curious, you actually go out into rural Nevada.
Yes.
What are you seeing out there that's changing in our communities? Especially, I mean, there's not a lot of access to doctors, I would think, in a lot of our rural areas.
And it really hasn't changed in the 22 years that we have been going out on the road and going to rural areas. I haven't seen any increase in the number of physicians, certainly not in my specialty. I'm still the only ophthalmologist that visits some of these rural areas, even after all these years.
And these are not small. You're talking places like Elko, Winnemucca?
Elko, Winnemucca, Ely. We've been to Fallon, and we did a lot of work in Fallon, but unfortunately the surgery center wound up closing there.
Really?
So we didn't have a place to do some of our work.
And yet, didn't they expand services into Fallon, at least to the Naval Air Force Base? So didn't that bring up the population to some extent?
Air Force tends to have their own medical care, so
Okay.
that may not have been the people we were taking care
but I
of.
think of just the families and the businesses that come in when you bring in more services to the Air Force Base. So,
There is a hospital there, and they do a good job,
Yeah.
but this private surgery center just wasn't able to survive with the number of physicians utilizing it.
Let's talk about new technologies, because there's been a lot of changes in the last couple of years in your field. Would you care to elaborate on that?
Well, I'm a cataract surgeon and a refractive surgeon. That means I change people's eyes so they see better without glasses, and then cataract surgery. Cataract's something that everybody is developing every second. Your cataract just got worse this last second. It takes a long time, it takes many years until they affect your vision, but this is something that will affect everybody. So the main focus of my work is cataract surgery, and in cataract surgery, just continues to evolve. We have better and better lens implants to replace the lens width when we take a lens out. So we can help somebody's vision be better and better, closer to what it has been during their lifetime with glasses on, and now replace their glasses with an implant so that they're less glasses dependent.
You were talking to me off air about actually how this works, that you can see things in real time now.
Yes. Time was that we would take measurements of an eye and we would predict what lens implant would be good for that eye after their cataract has been taken out. And we would go into surgery with that in mind, and we would have that lens in hand, and we would swap lenses. And by and large, the cataract surgery has always been very successful. But now it's getting a little bit more fine-tuned with the measurements. We now have the ability to analyze the eye optically in the middle of surgery. So we've taken the patient's lens out, and now we can do an analysis of their eye in real time to see what would help their eye focus the best. And we have hundreds of lenses on hand, so we can choose one that's closer to what they would need to be rid of their glasses. So that's been a good improvement in patients' vision without glasses after surgery.
See, maybe there's hope for you yet with those glasses. Of course, I have contacts, but my mother had cataract surgery, and her vision after 50, well, almost 70 years, her vision is almost 20/20 now. So I had no idea that when you do cataract surgery, I always thought it was a preventative thing, but it actually does improve vision, and I was just surprised to hear that.
Yes,
or
we
see
do
that.
not. We do not do cataract surgery as a preventative measure.
Yeah.
We wait until the lens of the eye is hazy enough that the patient is having some problems doing what they could do, reading street signs far away, sewing, reading, doing crossword puzzles, any of those things that patients have a decrease in their ability to do because they're not having as clear vision due to a cataract. Then it's time to consider cataract surgery. If we don't do cataract surgery right away, no harm done. The cataract doesn't damage the eye, but as time goes on, it gets worse, and they have more and more trouble with these activities of theirs. And eventually, they want that vision back that they used to have. So we get that vision back in most cases, and now, with the implants we have available and our ways of measuring it, we can do better than ever at getting them out of the glasses that they've always worn at the same time that we're doing their cataract surgery.
Yeah.
So is LASIK just a younger person's version of cataract surgery?
Not at all, not at all.
Okay.
Just
And
As
very,
you just
very
so happen
briefly
to
here,
have.
on the radio, we do have aids here, visual aids.
Yes.
I have a little eyeball in my hand. The cornea is the front window of the eye. The lens is a clear structure inside the eye. When this lens gets hazy, it doesn't allow light to penetrate as well and reach the retina in as good a focus. So we take the cloudy lens out, put a clear one in. That's cataract surgery or lens replacement. For younger patients who have a clear lens, but they need glasses, we can reshape their cornea somewhat into like the shape that their glasses are, so that the glasses prescription is then almost branded on their eye. But it's the cornea, we leave the lens alone.
And that's
So
where we have to leave it.
two
Dr.
different
Randy,
structures.
getting
I
in the
know,
business.
I
We'll be
know.
right back on Nevada Newsmakers after this time out. Thank you, guys.